Professor James Selfe, and I'm doing this presentation about red flags on behalf of myself and my colleague Sue Greenhalgh, who is consultant physiotherapist in Bolton. So the presentation today is about red flags, and we've divided it into 8 separate sections. These are introduction, historical perspective, what is the clinical evidence for red flags, a section about individual red flags, hierarchy of red flags, the clinical context of actually trying to identify red flags in practice, how to ask about red flags with your patients, and then how to manage red flags once you've actually found some, if indeed you do find any. Most of the work that I'm presenting today has been published in various formats. The 2 main sources are the 2 books that Sue and I have written together. So those are the source material for most of what you're going to see today. So, introduction. So first of all, we need to think about a definition of red flags. What are red flags? They are clinical indicators of possible serious spinal pathology, and they are physical manifestations of underlying significant medical pathology. So when we talk about medical pathology, what specifically are we looking for? We're talking about things such as benign or malignant lesions, infections, fracture, or called Aquina syndrome. Early recognition of serious pathology depends on awareness, vigilance, and suspicion, rather than on a very rigid set of rules. Greg Grieve was the first person to really describe this back in 1994, and it's a really important concept which underpins a lot of the work around red flags. In terms of physiotherapy, we have a duty of care. We've got over 2 decades of literature that talk about red flags, but what we found is that the documentation of red flags remains poor, and Ferguson et al. In 2010 reported that in physiotherapy. So we have a definite duty of care to identify red flags, and then the key thing is to know when onward referral or onward investigation or more expert help is needed. And so the red flags can be used as clinical signposts for you to move patients along the pathway. Section 2, historical perspective. When we look historically at red flags, the lists of red flags have changed over time. If we look back at the early work of Malignant from 1952, we see all sorts of conditions that we wouldn't necessarily recognise today. So we've got things like smallpox, influenza, gonorrhea, prostate cancer, acute kidney problems, multiple sclerosis, Parkinson's disease, TB, Paget's disease, appendicitis, sepsis, and bowel or teeth from tonsillitis, and even hemorrhoids. Now, some of these things we recognise today, some of them we wouldn't. What's happened is partly that there's been an evolution in terms of medical care, and so some of these conditions have been eradicated, and the pathways for these conditions have changed. So we may or may not come across some of these in our practice. We can see how the red flag list might have changed some years later when Syriax presented his list back in 1982. So he was referring to things such as backache with fever, neoplasm, root pain of more than 8-month duration or with gross limitation of every movement, weak psoas major, afebrile osteomyelitis, aortic occlusion, spinal claudication, and nutritional osteomalacia, gonorrheal fasciitis, and multiple root palsy, and finally the famous forbidden area that Syriax used to talk about. So we can see that some of these, again, we might recognise, we might not. Conditions such as TB, conditions such as HIV/AIDS have got a quite interesting history across musculoskeletal care. And particularly TB was something that a lot of practitioners would have discounted many years ago, whereas now TB is currently on the rise. The things with With conditions such as TB, one of the things to remember is that the context of where you work is really important. So in some centres, TB is going to be a lot more common than in others. So for example, in London, TB is going to be quite a key issue. TB is associated with poor housing, social deprivation, and a lot of other issues like that. So you get a sense that when you're asking about these kinds of conditions, we need to think holistically about the whole patient rather than specifically on narrow bands of red flags. Again, if we think about something like HIV and AIDS, 20, 30 years ago, it was a condition that none of us would have really considered. As again now, it's an issue where we need to consider this in musculoskeletal practice. Clinical practice versus scientific study. So historically, red flags were developed using astute observation and retrospective analysis, again using the example of Manel and Syriacs. Unfortunately, there's been a distinct lack of scientific study, and therefore, with a few exceptions, the prognostic strength of either individual red flags or combinations of red flags isn't known. So what is the evidence to support the use of red flags in clinical practice? There's actually very little evidence. Very little primary research has been undertaken in this area. If you look at a lot of the very important guidelines, so things like CSAG, AHPCR, European guidelines, Royal College of GP guidelines, a lot of these actually rely fairly heavily on secondary citations, and they are not presenting large bodies of evidence which support the use of red flags, which I think is quite interesting when you consider the relative importance and the relative weight put on these guidelines, and yet the evidence that they're using is actually, in many cases, absent or minimal. There's also very little or no high-quality evidence on the diagnostic accuracy of red flags, and on the limited evidence available, some red flags seem to have little diagnostic power. Henschke and Mayer in 2006 have strongly supported that particular view. According to Jennifer Claver Moffat in 2006, the evidence for red flags is underdeveloped, and Martin Underwood, Professor of General Practice in Birmingham, publishing in 2009, suggested that the strength of evidence underpinning screening questions for malignancy and fractures is weak. And again, I think that's quite interesting, because you would have thought that screening questions for something like fractures would actually be fairly clear. But according to Underwood in 2009, they're far from it. She concluded that there were few papers published, papers often suffered from very weak methodology, and papers were poorly indexed and therefore hard to find. In order to address some of the lack of evidence, Sue and I conducted a nominal group technique a couple of years ago. This was to inform the evidence base on red flags for malignant spinal pathology specifically. What we did was we utilised the experiential knowledge of specialists in the palliative care sector to inform staff working in the primary care sector. What we were able to do was, by asking people who worked with patients at the end of their cancer journey, was to reflect on the kinds of symptoms and the kinds of problems that the patients were reporting as being fairly common at the beginning of the journey. And this was quite an interesting process, because the clinicians we were talking to were actually dealing with confirmed cases of malignant spinal pathology. So there was a clear route to track back to gain this kind of information. The kind of results we found from this study were interesting in that they confirmed a number of the existing red flags for malignant spinal cord compression. So, for example, unremitting pain, history of current or previous malignancy, neurological deficit, bladder and bowel symptoms, failure to respond to standard evidence-based treatment, absence of previous back pain. These are all widely acknowledged already in the literature, and these were confirmed by our expert group. Interestingly, however, they highlighted 3 items which we hadn't previously come across in the literature, and these were band-like trunk pain, decreased mobility, and vague, non-specific lower limb symptoms. And these were things which we often come across in early stages of musculoskeletal practice and are often relatively dismissive of because they're quite vague and non-specific. But however, these did seem to be consistent themes which came through from this group of clinicians as items which patients themselves reported in hindsight as being things that they noticed. So we go on to section 4 now, which is individual red flags. If we look at single individual red flags, 80% of people with acute low back pain will have at least one red flag. So the presence of a single red flag does not usually help the clinician in deciding whether any further investigation or treatment is needed. If we look at how many red flags are actually available to us as clinicians, the clinical guidelines for the physiotherapy management of persistent low back pain, which the CSP published in 2007, reported that there are in the region of 163 individual items that could be considered as red flags. The way this was split was that 119 items were in the subjective history and 44 items in the objective examination. And clearly this presents a fairly major problem in terms of the clinical utility of trying to use individual red flags. There's no way we can carry around 163 items in our heads, and from a practical point of view, we're never going to try and assess 163 separate items in addition to all the other things that we might wish to do with our back pain patients. One of the interesting things that's come out of this is this split between the subjective and the objective. And with the work that Sue and I have done, we found this pattern that is repeated over and over and over again. So that it seems fairly consistent that the subjective examination is a lot more useful in determining serious spinal pathology and red flags than the objective examination. And I think that's a point well worth taking away from this. That if you've got limited time, if you ask the right questions, then you can often find an awful lot of information which is of relevance. Okay. Part of the key, of course, is trying to identify which the right questions are, which I'll come on to later. So again, just talking a little bit more about single red flags, Henschke et al. In 2007 published a systematic review of 6 studies that evaluated 22 clinical features that were used to screen patients with low back pain for malignancy. They found only 4 clinical features which, if used in isolation, were useful to raise the probability of malignancy. A previous history of cancer yielded a positive likelihood ratio of 23.7. Elevated erythrocyte sedimentation rate, or ESR, yielded a positive likelihood ratio of 18. A reduced hematocrit yielded a positive likelihood ratio of 18.2. And overall clinical judgment yielded a positive likelihood ratio of 12.1. Now, the way to interpret likelihood ratios is if you've got a score of more than 10, it's probably going to be important from a clinical perspective. Now again, if we take this list of 4 items and just analyse them for a few seconds, a previous history of cancer, very often patients in the first stages of their journey won't actually report that they have had a previous cancer. In addition to that, you will find a lot of patients will come through that don't actually know that they do have a history of cancer. So this is the first time they've contacted anybody from a medical perspective, and they don't actually realise that they've got cancer. So quite often, the previous history of cancer isn't actually that useful a question. Many clinicians do not have access to getting ESRs and hematocrits. So a lot of blood tests and investigations are not going to be available to a lot of people. But interestingly, overall clinical judgment the idea that physiotherapists either intuitively or tacitly have an understanding that there's something fundamentally wrong with this patient. And I think this overall clinical judgment is something that you should not underestimate within your clinical practice. Sue had a secretary where she worked at one time, and the secretary would be able to spot patients that were in very serious difficulty. And she would go into Sue and say, Sue, there's one out here you need to come and have a look at. So even people who weren't necessarily trained to look for these things could start to pick out some of these kinds of patients, which I think is quite an interesting thing. So don't underestimate overall clinical judgment. If we take night pain, which is commonly reported as a red flag, Harding et al. In 2005 conducted a prospective longitudinal study of 482 consecutive patients attending a back pain triage clinic. 213 patients reported some night pain, 90 patients reported pain every night. Patients had 5 hours of continuous sleep and woke 2.5 times per night. Interestingly, no serious pathology was identified in any of these patients. And the conclusion was that although a significant and disruptive symptom for patients, these results challenged the specificity of night pain as a useful diagnostic indicator for serious spinal pathology in a back pain triage clinic. So again, one of the classic red flags that most of us would consider to be important, according to this particular study, suggested that it wasn't that useful. So again, we need to review the evidence base regularly to see whether some of the red flags are or are not supported. Another study which was similar in that it looked at a specific and isolated red flag was the study by Buchanan et al. 2006, where they investigated whether age less than 20 may or may not be a red flag. They reviewed the MRI database from a specialist orthopaedic hospital to establish the incidence of tumour and infection in 403 patients who presented to secondary care with low back pain. Interestingly, they excluded patients who simultaneously presented with neurological deficit, fever, acute deformity and scoliosis. So once you'd removed all of those particular patients, they found that only 0.25% of young people with low back pain with no simultaneous comorbidity had serious pathology. But again, I think it's quite interesting when you look at the results in terms of which patients they've actually excluded from the study and whether you consider that the combination of these things alongside age would actually be an important factor. And that we'll talk about the combinations of red flags a bit more in a minute. We always need to think about the red flags in context. So clinicians should not uncritically accept any one red flag in isolation. The context is crucial. And Claver Moffat et al. In 2006 published this statement. And again, we need to consider the chicken licking sort of scenario. One red flag and the world is not falling in. We've got to think about the overall context that the patient is telling us about. So if we think about the context, patients with a previous diagnosis of cancer will be diagnosed significantly more quickly than those with no prior diagnosis. And this was published by Levac et al. In 2002. A previous or current history of cancer will immediately raise the clinician's index of suspicion. So we now move on to section 5, which is the hierarchy of red flags. So guidelines usually list individual red flags and leave their interpretation up to individual clinicians. However, a more effective screening tool could be recommended if data were available on how to use red flags in combination with each other. According to Henschke et al. In 2010, ideally an effective series of red flag questions for spinal malignancy would highlight pertinent characteristics from the patient's history and physical examination. And to some extent, there is a system that allows you to combine the red flags. This particular version was published by Deo and Deal back in 1988. And although there's often criticism from academic physios about using publications which are more than 10 years old, this is a particularly pertinent piece of work, and it's a classic piece of work which we need to consider. So what Deo and Deal found was that age over 50, history of cancer, unexplained weight loss, and failure to improve after 1 month of conservative therapy gave a sensitivity of 1 and a specificity of 0.6. So if a patient comes in with that combination of factors or that combination of red flags, you can be almost certain that they're presenting with a cancer. Okay? So it's a really important combination that we really fix in the back of our minds. Sue and I kind of tried to develop that concept in the first book and followed it up with a revision in the second book, where we presented a hierarchy of red flags, where we presented a system of 4, 3, 2 and 1 red flag. The combination of Deo and Deal was the only combination that we gave 4 red flags to. The other things that were in the list, we then either gave 3, 2 or 1 as a sort of weighting system. So if I just go through some of the features or some of the red flags on the system and explain how we came up with some of the weightings. So for the 3 red flags, we had items such as age less than 10 or age over 51. So if we think about this for a few minutes, we have to think, why on earth would a child that's an 8-year-old come in with significant low back pain? Okay. For most of us, we would consider that to be somewhat unusual. If somebody comes in with an age of over 51, a 60-year-old patient comes in with a first-time history of back pain, they've never had back pain before, why would somebody at that age suddenly start to have back pain? The peak incidence for back pain is somewhere in the 40s. Why would somebody that's never had it before start at over 60? If we look at some of the graphs of age groups and cancers, we'll see that there's a decade-on-decade increase in the numbers of cancers. But what you'll often find is that there's a very steep change in the curve round about the age of 50, and there's a much, much higher incidence after the age of 50 compared to below the age of 50. And that's why we decided that the threshold would be around about 50. If we look at previous medical history, we've got things such as cancer, TB, HIV/AIDS or injection drug abuse, osteoporosis. And again, particularly with things like TB, HIV/AIDS, we need to consider the environment in which you're working. Okay? Osteoporosis, again, we may need to think about the age of the patient. One of the things that we spent quite a bit of time looking at was weight loss. If you look at most of the major guidelines, including guidelines such as CSAG, they'll all include a phrase which is something like the patient will experience significant weight loss, significant unexplained weight loss. Now, one of the things that we realised was that there didn't seem to be any good guidance as to what was a significant amount of weight. The unexplained part seemed reasonably straightforward. So we spoke to a number of dietitians about this, and this is where we came up with our sort of formula, if you like. And what we looked at was a number of dimensions. So we need to consider how much weight loss, and one of the things that the dietitians were quite keen on was the idea that we were looking at weight loss as a percentage of body weight rather than as an amount of total weight. So the daft example that we often use is that if Arnold Schwarzenegger comes in and he's lost 5 kilos, then he's lost half of his biceps. If Kate Moss comes in and she's lost 5 kilos, that's equivalent to a whole leg. So I know it's a daft example, but it does get across the idea that the same amount of weight in different individuals counts quite differently. So if we express that as a percentage of the body weight, it becomes a lot more meaningful for the individual patient. The next dimension you need to consider is the time frame over which the weight has been lost. And the dietitians were suggesting that a sort of 3 to 6 month period was actually quite a significant length of time to be losing large amounts of weight. So, for our 3 red flags, we came up with an idea that weight loss of more than 10% of body weight during a 3 to 6 month period for no apparent change in the patient's lifestyle or eating habits would be something that we would consider to be quite an important feature. Okay? But again, we need to consider, has there been any change in diet? Has there been any change in lifestyle in addition to that? Okay? Despite some of the evidence that I've already quoted, we still feel that severe night pain is quite an interesting red flag, and we've actually kept that in the list. And the kind of night pain that we're talking about are the patients that have to sit in a chair, they can't lie flat, they're crying with pain at night. And this sort of picture is slightly different to the kind of picture I was painting earlier in the back pain triage clinic. So this is a very severe kind of night pain. Then we've got called Aquina syndrome, which I'll talk a bit more about later, and then positive extensor plantar response, or the Babinski reflex. All of these items retain a weight of 3 red flags. So we move down the list to things which are slightly less important. We'll still be perhaps concerned about them, but not quite so alarmed. Age 11 to 19, weight loss 5 to 10% of body weight during a 3 to 6 month period, a constant progressive pain, an inability to lie supine, abdominal pain and changed bowel habits, but with no change of medication. And again, it's very important with these kinds of questions to understand the chronology of what's going on, because with a lot of the medications for back pain, they often have a constipatory effect. And so you need to understand what the chronology is. So has the change in bowel habit occurred pre or post having to take some sort of medication for the problem which the patient has got? Bizarre neurological deficit, spasm and disturbed gait. And again, the disturbed gait, the sort of clumsy disturbed gait, does seem to be quite an important thing in very early stages of malignant spinal cord compression. And then if we go on to the 1 red flag list, we've got weight loss of less than 5% of body weight during 3 to 6 months, smoking. And again, with smoking, we need to understand how much smoking has occurred over what time frame. And again, be careful with the question, do you smoke? No. Have you ever smoked? Yes. When did you give up? Yesterday. It gives you quite a different picture. So always make sure that you explore some of these issues thoroughly and don't necessarily take the first answer the patient gives you. Systemically unwell, systemic steroids, bilateral pins and needles in hands or feet. Again, previous failed treatment, but again we need to think, is that evidence-based treatment? Thoracic pain, changes in physical appearance, and the marked partial articular restriction of movement. So if we actually applied this system of red flags to a real patient, we've got this example here where we've got a patient that's age 53 with constant mechanical pain, non-mechanical pain, widespread neurological problems, and a past medical history of carcinoma. If we look at how the CSAG weighting would generate a red flag list, we end up with a total of 3 red flags if we look at this particular patient. If we use the red flag hierarchy that Sue and I have just been talking about, we end up with a total number of 10 red flags. So again, in terms of trying to help clinicians and try and help understand the importance of some of these things, using the red flags in combination will help to highlight your index of suspicion. And if your index of suspicion is heightened, then you may be triggered into signposting the patient into the next stage of their journey. So So section 6 is the clinical context of trying to identify red flags. Again, one of the things which, when we talk about red flags, we're at great pains to try and remind people and point people out, is the simple back pain pyramid. Okay? 95% of back pain is simple backache. Approximately 5% of this is nerve root pain, and less than 1% is going to be serious pathology. So again, it's really important to remember that within the totality of the back pain population, the kinds of things that I've been talking about today are actually reasonably rare. Okay? Or some people say they're very rare. It does depend on the context. If you're working in a specialist spinal centre, the chances of seeing these kinds of things will go up. If you're working in a relatively straightforward, routine, general practice primary care setting, the chances of seeing some of these things is going to go down. I think Underwood actually makes the comment that for most clinicians, a Aquina syndrome will be a once-in-a-lifetime experience if they ever see one at all. So I think that does help to put it into context. But again, he is talking specifically about a primary care setting when he says that. Now, one of the things to bear in mind when we are thinking along these lines, that this is actually relatively rare, is the Occam's razor, or the principle of parsimony. And this is often expressed as the difference between the zebra and the horse. And the expression is that if you're lying in bed at night and your window was open and you heard the sound of hooves outside on the pavement, what would you assume the animal was making the noise? Would you assume it was a zebra, or would you assume it's a horse? So clearly, if you did hear that, you would have to assume it was going to be a horse. Okay? You've got to think of the obvious, you've got to think of the most sensible. Don't go around thinking that many of these patients have got red flags and have got serious pathologies when they actually haven't. Keep it relatively real and straightforward. Okay. So just to reiterate, when we're talking about serious pathology, we're talking about benign or malignant lesions, infections, fractures, or chordae equina syndromes. Okay. So previous history of cancer and metastases. Breast, prostate, both have an 85% chance of metastases into the spine. So these are the two cancers which cause metastases in the spine most commonly. Okay. Lung cancer, thyroid and kidney are also cancers which can cause spinal problems. So again, you need to understand whether there is any family history of these conditions. So a female patient that complains that her, or rather reports, her mother and her sister both have breast cancer, your index of suspicion needs to be raised. So again, with cancer, you need to find out about first degree and primary relatives, so brothers, sisters, mothers, fathers. What sort of illnesses did they have? And is there a chance that the person sat in front of you has got something similar to them? So it's always worth asking about that family history. If we're thinking about fracture, a medical history of osteoporosis, a current history of systemic steroids may be important questions. Age and the presence of trauma. And again, if somebody has sustained a relatively mild or what you would consider to be a trivial trauma and they've sustained a fracture, you need to start to think, why? Why would somebody fracture with this level of force or with this level of violence? And if it's relatively low, then be suspicious. Infections are quite rare, and these are the TBs, HIV, AIDS, or injection drug abuse. Now, although I've said they're rare, again, it does depend on the context, and deprived inner city areas are more likely to see more of these kinds of patients than perhaps some of the more leafy green suburban and rural areas. Okay? And patients that have abused systemic steroids in the past may also suffer from some sort of infection. Other things that might help you think about infection are patients with very, very low BMIs, a BMI of less than 19. People with that level of BMI tend to be more prone, more susceptible to developing infection. Poor living conditions, overcrowding, homelessness, refuges, hostels, people living in those kinds of conditions may well be more susceptible to infection. If you're actually exposed to TB, you need to be exposed to it for more than 8 hours for the chance of you actually developing it to become significant. Patients who are not originally born in the UK and patients who were not originally vaccinated against TB are obviously going to be a higher risk for some of these infections. Right, so if we just briefly talk about Aquina syndrome, again quoting Deo et al. From 1992, and he actually lists the sensitivity of different questions for investigating Aquina syndrome. So urinary retention is 0.90 sensitivity, unilateral or bilateral sciatica is just over 0.80 sensitivity, as is sensory motor deficit and reduced SLR. But saddle anaesthesia is down at 0.75. So it's interesting to just look at how the different questions have different weights. So one of the things that Sue and I have currently got a project where we're investigating Aquina syndrome, and specifically we're actually asking patients about how best to ask some of the questions, because clearly with Aquina syndrome, patients will often find the questions somewhat embarrassing when you're investigating about bladder, bowel, sexual function. And if they're in severe back pain, it can sometimes seem rather abstract that the physiotherapist is asking them what they feel are quite inappropriate questions. So Sue and I are doing a piece of work where we're actually working with patients to see if there's a system whereby we can actually frame these questions in a more sensitive way for patients, and a way in which patients will start to realise the importance of why physiotherapists may or may not be asking these kinds of questions. The other aspect of the project is, of course, to then try and understand, once we've got the information from the patients, information from physiotherapists about how best to ask the questions, because similarly, a lot of physiotherapists actually find it quite difficult and challenging to ask questions of that type of nature to their patients. So that's a piece of work which is ongoing, and I would hope that we should be able to be publishing something on that in probably 2013, I would imagine. One of the things that we need to consider is the timeline when we're thinking about red flags. Many patients will report to their pain to their primary care clinician within about 3 weeks. Okay? So from the onset of pain to turning up at a GP surgery or in a primary care physiotherapy centre is about 3 weeks. Now, if that patient is in the very early stages of a cancer journey, it's going to be very difficult to actually understand what particular pathology may be responsible for their pain. Because the mean time to diagnosis is approximately 2 months. So you've got that gap between 3 weeks and 2 months where the patient may or may not be having physiotherapy, they may or may not be responding to physiotherapy before they actually get a definitive diagnosis. One of the other things which crops up time and time again on postgraduate courses is the fact that an awful lot of these patients seem to arrive on a Friday, and in particular on a Friday afternoon. So one of the things that you need to think about in your local area is, do you have a pathway about how to manage the very complex or serious case that turns up late on a Friday afternoon? And that really, it sounds an insignificant thing to say, but it's a really important practical point which I'll come back to again later. So many patients present on a Friday. Do you have a pathway in place to manage that patient when they turn up at that time? So, in the early stages, many of the patients will not have lost any weight. They may not have constant pain. They might not have night pain. And what we will find is a lot of patients will actually respond to treatment for a short period of time. So there's this apparent improvement. And again, from a physiotherapy point of view, as soon as you see a patient start to improve, it's a really strong message that everything's okay, and it really helps to reassure the physiotherapist and the patient. But quite often, the secret here is that the improvement, or the apparent improvement, is very temporary. So you do need to monitor patients quite closely at the beginning of their journey. Another very common feature in the early stages is that patients will often attribute their pain to a very specific cause. And it may be something quite trivial, like picking up a bag awkwardly or moving with a shopping trolley awkwardly. And it just seems to be a human phenomenon that any pain that you have must have a reason. The idea that pain can just come on for no real reason or no apparent reason seems quite difficult. So you will often find that there is this misattribution to some inconsequential event, which can sometimes deviate the course of clinical practice, which isn't very helpful. And of course, we have to remember that a lot of patients in very early stages may have an undiagnosed, unknown, symptomatic primary tumour. And again, the example of breast cancer is very common in clinical practice. So going back to our nominal group technique that I mentioned earlier, when we were trying to understand the very early stage of the patient's journey with cancer, and we were talking to our oncologist and palliative care colleagues, we've got some quotes from that particular piece of work, which I think are quite helpful. So I'll just read this out. The early ones usually say their legs misbehave somehow, that they won't do what they want them to do. Their legs won't behave themselves, but they often won't present with this until it becomes much more severe, because the patients can't explain, or they're not sure, or they don't actually know the significance of the fact that their legs are not doing what they want them to do. So this pattern of this sort of leg misbehaving is a really important finding and shouldn't be underestimated in a patient coming in for the first time with back pain. So patients finding that their foot drops a little bit or that their right leg drags a bit, they really don't know the importance of that until much more serious symptoms and signs have actually developed. So again, this was one of the things which we really picked up and we found very useful to help in the early stages of musculoskeletal practice in primary care. This has led into the development of these red flag early warning cards for the malignant spinal cord compression. So this was developed in collaboration between NHS Bolton, University of Central Lancashire and Greater Manchester and Cheshire Cancer Network. And these cards have now been produced by the Cancer Network, and I believe that they are available quite widely here in Scotland. So, section 7, how to ask about red flags. Day of Rainville and Kent, 1992. I've already mentioned this. The subjective examination provides clinicians with clearer indications of serious pathology than the objective examination. Remember, 119 subjective red flags and just 44 objective red flags. The key to a lot of the patients is in the subjective. The thing is making sure you ask the right questions. So when it comes to a diagnosis, therapists should not be alarmist, as many patients present with some red flags in the presence of completely benign conditions. Again, I've already mentioned that. A lot of people will have at least one red flag. Over-medicalisation and investigation of benign pathology can cause the patient a great deal of stress, so we have to avoid that at all costs. The therapist has a professional duty of care not to cause any needless anxiety or concern for the patient or indeed their family. So, when you are asking questions about red flags, you sometimes need to frame them. As I said previously, sometimes when we ask questions of patients that are in severe back pain about their bladder or their bowel, they can't see the relevance of that. They seem to be abstract questions for the sake of it. So to preface this, you can sometimes use phrases like, I'm now going to ask you some really important questions. This sort of phraseology will help focus the patient's thought processes. And as I said, patients actually themselves report that some of our questions as physiotherapists do not appear to have face validity when they're in a lot of back pain. And as I've just said, what has my bladder got to do with my back pain is a common example of that. So, how to manage red flags, section 8. Once you've actually identified a patient that you're concerned about, you think this patient may have red flags, what do you do next? It's a very important question. So in clinic, what do I do once I've found a number of red flags and I am suspicious that this patient does have a serious pathology? Well, there's very little doubt about this. All the literature that we've found all concurs and it all agrees with the same point. If you find serious pathology, it advises you need to refer for early specialist opinion. Okay? You've got to move the patient to the next stage of the pathway, to the next stage of their journey as soon as you possibly can. Don't delay. So, in a clinical environment, when faced with this situation, you need to reassure the patient appropriately, but don't create unnecessary anxiety. You need to be prepared for the question, do you think that something is seriously wrong with me? Okay. In response to that kind of question, a phrase such as, I think that we need to look into your problem a little further so that we can see more clearly what is going on. We need to make absolutely sure you're given the best and most appropriate treatment by the right people. That's the kind of phraseology which is quite useful in these situations. If you suspect a malignant spinal cord compression, which relates back to the credit card that I showed you a few minutes ago, most of the advice suggests you need an urgent MRI within 24 hours, and that should be of the whole spine. And if there is confirmed malignant spinal cord compression, then an emergency decompression or radiotherapy are the treatments of choice. But again, one of the key things that you need to understand is what is your local pathway for managing these kinds of conditions. So, musculoskeletal clinicians need to ensure that the patient is referred to the correct service to get the most appropriate treatment underway without delay. So it's the phrase, the right person in the right place at the right time. Okay. If you have a role as an extended scope practitioner, if you are considering ordering investigations, then Asher, back in 1954, offered some really sound advice. And the advice is this: you have to consider, what am I going to look for in the results of any of the tests that I'm ordering? If I find that result, how will it affect my diagnosis? If I find that particular diagnosis, how will this affect my management, and how will this ultimately benefit the patient? So again, the idea here is to think through all of the consequences. If you're ordering tests, why are you ordering the tests, and what's going to happen to the patient once you've got the results? And you need to think that through before you actually order the tests, or else again, there's potential that the patient could be misdirected and time could be wasted. So finally, you've now found your patient and you're seriously concerned that they do have a genuine, serious pathology. You have to think, as I've emphasised a number of times in these last few slides, will I know what to do on a Friday afternoon? I've got the results of these tests back. They've come back at 3 o'clock on Friday. I've got a patient in clinic, 3 o'clock on Friday afternoon. I'm seriously concerned. What do you do now? What is the pathway? And is that pathway set up and ready to go for you to access at 3 o'clock on Friday afternoon? Okay, so that's the complete set of slides. The presentation is finished. Thank you for your patience and listening to this, I'll sign off now. Thank you. Goodbye.